No. Good afternoon and welcome to our Community College Oncology Lecture Series on February 27th, 2017. I'm Tim Poe. I'm Director of Telehealth with the UNC Cancer Network. Thank you so much for being here today. We're really glad to have all the community college students and community college faculty with us for this presentation today. Let me go through a few things first and then we'll get right on to our presenter. First off, if you need us for any reason having technical difficulties, unccn@unc.edu, that's the email. You can call or text 919-445-1000, and then we'll talk about Poll Everywhere in just a minute, and that's how you can submit answers to different questions and get involved with our Q&A at the end. We're on Facebook, we're on Twitter, we're on YouTube. We hope you'll find us there, and on the web at unccn.org. All right. With that in mind, we've got a poll to start off with. So in the U.S., 1 in blank men have a lifetime risk of developing prostate cancer. So this is the poll that we're going to have, and you can go to pollev.com/UNCCN, and you'll see this and our other polls. You can answer them that way. More popular way to answer our polls is using your phone, and any phone that texts, you can text 223. You can text to 22333. So that's the number you'll text to, and you'll text the letters UNCCN. So you're going to text the letters UNCCN to the number 22333. Do that one time. That joins you to our Poll Everywhere texting, and then you can go ahead and submit answers to questions. So the question here, in the U.S., 1 in how many men have a lifetime risk of developing prostate cancer? Is that A, 3, B, 5, C, 7, or D, 9? And if you'll go ahead and do that now while we do introductions, we can take a look and see what you think in just a moment. All right, Mary Dunn is a nurse navigator, or a nurse practitioner in the Department of Urology at UNC Hospitals. Mary joined UNC Urology in 2010 and has served as adjunct faculty for the UNC School of Nursing since 2011. Mary works in a multidisciplinary NP role, providing care to urology and medical oncology patients with you're going to have to help me with that one.
Genitourinary.
Thank you. Yes, genitourinary malignancies. Mary received her Bachelor's of Science in Nursing from the University of Virginia. She completed her Master's in Science in Nursing at Duke University. Mary, welcome.
Thank you.
We're very glad to have you here today.
Thank you for having me.
Maybe you can start off by letting our audience know what led you to a career in oncology, and what was the path that took you from your initial studies into the career you have now?
Yeah, that's a great question, one that I really enjoy answering. I went into nursing school convinced that I was going to be a pediatric nurse. And then I said, well, no, I'm going to be a labor and delivery nurse. And then I had my clinical rotations in both of those and said, absolutely not. I can't. I'm not cut out for this. So I was lucky enough to be able to score kind of a coveted spot in an oncology clinical rotation my 4th year in undergrad. And that's when I learned that my true passion was oncology. And that's how I kind of branched into being an oncology nurse.
Well, that's great to hear. And of course, one of the reasons that for this series, we hope that it will help all of the students to know more about oncology and a lot of the issues around oncology, and perhaps influence some of them to want to select a career in oncology themselves. All right. Well, let's take a look at that poll and see what we found out. And that should pop up in just a moment here, or 2. Or 3. Usually comes up pretty quickly.
It's Monday, so I understand.
There we go. Oh, I don't think I've ever seen it split quite so equally. So we have 25% for 3, for 5, for 7, and for 9. Will you please illuminate our audience and let them know which one is correct?
The correct choice is C, 1 in 7 men.
1 in 7, so pretty high.
Yeah, it is.
All right. Okay, well, with that, we'll go ahead and give you the controls here and caring for the patient with prostate cancer.
Thank you. I've got the controls. This could be dangerous now. Thank you so much for this wonderful introduction. I'm really delighted to be with all of you today, and hopefully can teach you some about prostate cancer and maybe something that some of you already know, since it is such a a common cancer. You may already have family and friends or perhaps yourselves who have been personally touched by this disease. I'm happy to speak with you about it today. So these are objectives which I believe that you have in front of you. They're pretty standard objectives, and I hope to touch on most of these points throughout the entirety of the presentation. So what is prostate cancer? So prostate cancer is the process that happens when malignant or cancer cells form inside the prostate gland. And the picture there is just a very basic picture of the male genitourinary anatomy, part of it, the lower part of it, I should say. So the bladder, and then right below the bladder sits the prostate gland, through which runs the urethra, which is the tube that kind of runs through the penis where urine comes out of. So what exactly is a prostate? So first and foremost, only men have prostate glands. It's partly glandular and partly muscular that sits within the lower pelvis. It's an accessory reproductive gland. So what does the prostate do? It really helps just secrete the substance that comes out when a man ejaculates. It has 4 zones. The peripheral zone accounts for 75% of all prostate cancers. So when we go in and we do these biopsies, we most likely to find them within the peripheral zone. You'll probably hear, and you've probably heard if you've heard anything about prostate cancer, that the prostate is about the size and feel of a walnut, and for the most part that's true when it's kind of in its normal size. So this is just another picture that gives kind of a sideways view of the male pelvic anatomy. So let's talk about the pathophysiology of prostate cancer. In other words, how does it act? What does it look like under the microscope? So 90% of prostate cancers are adenocarcinomas. In other words, an adenocarcinoma is a type of cancer that arises from a gland. So the vast majority of these cancers are adenocarcinomas when we look at them underneath the microscope. The remaining roughly 10% are neuroendocrine tumors, which act very differently than kind of standard adenocarcinomas. The majority of this lecture is going to focus on treatment of adenocarcinomas, since neuroendocrine tumors are relatively uncommon. So where does prostate cancer go when it does go outside of the prostate gland? It can travel through the lymphatic system and also through the hematologic system or the vascular system. And it can go to surrounding pelvic lymph nodes. Distant metastases typically go to bones in the axial skeleton. So for example, in the sternum, the rib cage, or the spine. Lymph nodes, like I mentioned, and then other organs such as liver, lung, for example, and brain are much less common in prostate cancer. So prostate cancer, especially advanced prostate cancers, kind of rely on this hormone pathway, which I'm going to use the cursor here to kind of show you. This is kind of a complex process. It starts in the hypothalamus and the pituitary gland. But what we really focus on with prostate cancer is testosterone production, and where the majority of testosterone production comes from is in the testicles. So about 90 to 95% of testosterone production comes from the testicles, and the remaining, it comes from the adrenal glands. We'll touch on this a little bit more when we talk about treatment of advanced prostate cancer. So epidemiology. Prostate cancer is the most commonly diagnosed malignancy in men. I think my next slide will have a picture of that and how it compares with other cancers. There are upwards of 3 million men living with prostate cancer in the United States, and like we touched on at the beginning of the talk, the lifetime risk is 1 in 7. It is the second leading cause of cancer death. 1 in 38 men who are diagnosed with prostate cancer will die of their disease. The newest numbers from 2016 show that there will be about 162,000 new diagnoses of prostate cancer this year, and roughly 26,000 deaths from the disease. So this is just a schema that comes from the American Cancer Society. These are the 2016 numbers, which look to be about roughly the same as the 2017 numbers, not a vast difference. I like to use these graphs from the SEER database that kind of give you an example of whether or not prostate cancer is a localized disease, which means just confined to the primary site, in this case the prostate. And you can tell by this pie chart here that for the most part, the vast majority, upwards of 80% of prostate cancers at the time of diagnosis, are localized and have not traveled outside of the prostate gland. What are some risk factors for prostate cancer? Well, being a guy, sorry guys, that's kind of the number one thing because you're the only ones out there who have prostate glands. But age is a significant risk factor. The vast majority of prostate cancers are diagnosed in older men, so men who are older than 65 years. Race is an important risk factor that we keep in mind, especially when we're talking about screening for prostate cancer. So African American men have the highest incidence and the highest mortality from prostate cancer. There's been a lot of folks who have studied this. The rationale for this, the reason for this is honestly not quite clear. Complex socioeconomic disparities have long been studied, and as far as why African American men have a higher incidence in mortality. Family history is also something to keep in mind, especially when talking to men about whether or not to screen for prostate cancer. Men who have a first-degree relative who has prostate cancer have a twofold risk of themselves developing the disease. Other risk factors that have been studied quite exhaustively are things like diet and supplements. So there have been large clinical trials that have been done in the United States and abroad, particularly in Europe, looking at whether or not dietary intake or certain supplements play a role in the development of prostate cancer. The bottom line is that there is no conclusive data exists that show that either of these things is a risk factor. Other things that we take into consideration, so that should be BMI, I apologize for the typo, body mass index, inactivity, exposure to certain chemicals, vasectomy, etc., have little to no evidence that show that they put men at higher risk of developing prostate cancer. These are two clinical trials, very large randomized controlled clinical trials that study two very commonly prescribed medications to treat BPH. BPH is benign prostatic hyperplasia, which is a fancy medical word for big prostate. So these two studies were looking at whether or not either one of these medications could conclusively be used in the prevention of prostate cancer. So what either of these trials showed us, roughly 25% in either of the trials, was that there is a reduction in prostate cancer, but more likely to have a more aggressive cancer. We're not really sure what that means. In interpreting the data that was done and presented from these two trials, we don't think that these drugs cause prostate cancer. One of the theories is that perhaps over time, the medications shrink the prostate, so that's actually what they do. Their mechanism of action is such that they shrink the prostate gland by about a third. So perhaps by shrinking the prostate gland, when men then had subsequent prostate biopsies, we had a smaller surface area to work with, therefore maybe just finding prostate cancer more than we would have in a larger gland. Neither of these studies looked at prostate cancer mortality, and neither of these medications has been approved by the FDA for prostate cancer prevention. So the drugs in question are finasteride and dutasteride. Nutrition has also been looked at quite extensively as far as, can nutrition intake of certain things prevent prostate cancer. There have been very large studies, so there's been a study looking at fruit and vegetables. This was a big study that was done in Europe. There have been studies done about selenium and vitamin E and vitamin C, whether alone or in combination, and none of these studies actually showed a decreased incidence of prostate cancer. So there are no nutritional supplements that are recommended for prevention of prostate cancer. It's important, I think, to counsel patients to avoid spending a lot of money on costly supplements that aren't backed by evidence-based. So what I typically do with my patients is encourage a healthy lifestyle. So balanced diet, exercise, avoiding tobacco, minimal alcohol, those things. So basically anything that's heart healthy, we also believe is prostate healthy. So screening for prostate cancer. I could probably talk to you for the entire hour about prostate cancer screening. It is by far one of the most hotly debated topics in medicine today. So the question with prostate cancer screening largely is, are we over-screening folks, therefore leading to over-diagnosis and over-treatment? A lot can be said about this. Like I said, if I had a whole entire hour to dedicate to this, I would. But I'll touch on some of these points in the next couple slides. So this is really to outline that as far as the major medical groups go, none of them really agree. So the only consensus is that men should be presented with benefits versus risks. So these are just a couple of the medical groups that have come out with best practice statements. So the AUA is the American Urological Association, ACS is the American Cancer Society, USPSTF is the United States Preventative Service Task Force, which I will eventually be able to say one day. And then I think ACPM is the American, something about primary medicine, I believe. The reason why I highlighted the USPSTF is that in 2012, they came out with an update that you may have seen was all over the news about we should not be screening men for prostate cancer. The potential benefits certainly do not outweigh the risks. The problem with this statement was many things, but what's come to light recently is that there was an analysis done that showed that the major clinical trial that led to this recommendation showed that the control arm of the clinical trial, in other words, men that were not supposed to be screened for prostate cancer, approximately 90% of them had actually been screened for prostate cancer, which leads to a tremendous amount of questions about whether or not this is clean data, when clearly with that kind of revelation it's not. So they are currently in the process of updating their recommendations based on this information that's come to light. So I'm imagining we'll see a lot of updates and maybe a little bit of backtracking when they have time to fully analyze the data. So the reason why prostate cancer screening is so hotly debated is, number one, we don't have a perfect tool for it. So the two things that we use most commonly are an examination of the prostate. That's called a digital rectal exam. So that's when the examiner puts his or her finger into the man's bottom to feel the prostate. The reason why that's imperfect is because we can only feel the back side of the prostate, the posterior aspect. So we can't reach around and feel the front part. If I ever tried to do that, I think I'd probably end up leaving clinic with a black eye. So it's imperfect because we can only feel the back part. And then the second part of the screening process that we use is a blood test called a PSA, which stands for prostate-specific antigen. The reason why this is imperfect is because if it's elevated, that certainly does not mean that a man has prostate cancer, because there are a lot of other things that can cause PSA elevation. So I have this list for you here. So infection, such as prostatitis or any kind of lower urinary tract infection, inflammation, urinary retention, prostate size. So if men have a large prostate, age, as men get older, PSA becomes a little bit less reliable. Abnormal cells, which are not cancer cells but are not normal cells, they're kind of these in-between cells, and of course prostate cancer. There are other things that can actually decrease the the PSA. So 5-alpha reductase inhibitors are those two medications I talked to you about earlier that reduce the size of the prostate. They actually cut the PSA number by half. So when we draw it, we have to double it. So for example, if we draw a PSA and it comes out to be 2, that's a true PSA value of 4. So PSA is not perfect, but unfortunately right now it's the best thing we have. So the great debate is largely, can we justify these mass public screenings to detect prostate cancer? So we have to think about things like cost, psychological impact of telling a man they may have cancer and then maybe they don't. There's 6 randomized controlled clinical trials that serve as the basis for these screening recommendations, but there's really little clarity regarding screening and impact on mortality. The financial aspect, so does the cost spent on screening prolong life or prevent unnecessary death? And then clinically significant versus insignificant prostate cancer. There are a lot of prostate cancers that we find that may not even need to be treated. And there are certainly some that do. We don't have a great way of predicting that based on PSA and prostate exam and family history. So we're still hoping that there's going to be some more useful tools that come out to help with all of these things. There have been some things that have kind of come into mainstream play recently. There's a prostate MRI, which is a very fancy X-ray tool. This is not appropriate for screening. In other words, it doesn't take the place of PSA or prostate exam, but can be helpful for men perhaps who have had multiple elevated PSA values with a negative prostate biopsy. Maybe we can use this to see is there something in the prostate that we're missing. And then there's biomarkers. I'm not going to go through all of these individually, but these are some biomarkers. Some of them are blood tests. Some of them we use off of the prostate biopsy tissue sample to see, should we biopsy someone to begin with? Who do we re-biopsy? And once prostate cancer is diagnosed, can we recommend surgery versus intervention for these folks? So there are some things that are kind of coming down the pipeline, but none of them is quite perfected just yet. So clinical presentation. The vast majority of patients with prostate cancer have absolutely no symptoms whatsoever. If men come in and they say, I get up, 2 or 3 times at night to empty my bladder, or, I think I'm peeing more frequently than normal, those, quite honestly, are usually more symptoms of BPH or enlarged prostate versus prostate cancer. Bad prostate cancers that are either locally advanced or that have traveled outside of the prostate can present with more concerning symptoms like severe lower urinary tract symptoms, pain in the bones, renal failure from not emptying the bladder, and even something that's an emergency, which is spinal cord compression. So how do we diagnose prostate cancer? Once shared decision-making has been made to screen between a man and his healthcare provider, whether that's their primary care provider or their urology provider, we do it with PSA, digital rectal exam, as we've touched on, and then we do a prostate needle biopsy. So the vast majority of these are done with patients awake. It's an in-office procedure. A man will lay on a table on his side. We insert an ultrasound probe in through the bottom so that we can see the prostate up on a television screen, and we take measurements, and that helps guides us when we're actually taking the pieces of the prostate. We do numb up the prostate gland with lidocaine. That's the part that most men say stings a little bit, but then the prostate gland kind of goes numb, goes to sleep, so that when we're taking the pieces, men shouldn't feel it. We typically take about 12 pieces or 12 cores, and then we send them off to the pathologist, who's the person that looks at them under the microscope and lets us know what it is, either cancer or not. This requires minor preparation, so they have to take an antibiotic pill. They have to clean out their rectum with a Fleet's enema to remove any stools so we can see better, and they have to stop any medications that thin the blood because there is a chance of having some bleeding after the procedure. It usually takes us about a week to get the results back. The way that we determine if they have prostate cancer, how aggressive it is by using the scoring system called a Gleason scoring system. So that's just a fancy term for how aggressive or not the cancer cells look underneath the microscope. How the pathologist grades this is by looking at the core and saying, okay, there's prostate cancer cells in here. What's the most aggressive pattern? And then they give that a score. And then they say, what's the second most aggressive pattern? And they give that a score. We add those two numbers together to get the total Gleason score. For example, 4 plus 3 being a Gleason score of 7. The best Gleason score that one can have is a 3 plus 3, which is a 6. The worst being a 10, meaning the most aggressive, and then everything else is kind of in between. Currently, there is a new grading system that's coming out that is going to replace Gleason. It's typically the same thing, but the wording is a little bit different. But for now, we're continuing to use the Gleason score. So how do we stage prostate cancer? So staging of a cancer means is it kind of outside of its host? In other words, is it localized? Is spread to other parts of the body. So in prostate cancer, it's a little bit different than other cancers. So the variables that we use are the blood test, how their prostate feels, what their biopsy results are, the Gleason score, and any imaging. So by imaging, I mean any X-ray test. Not all patients with prostate cancer should receive imaging testing. In fact, the vast majority of prostate cancer patients don't need to have fancy staging scans with CT scans and bone scans because the vast majority of prostate cancers aren't far advanced. So any patient who has a Gleason score found that is an 8, 9, or 10, we do recommend them having additional imaging testing to make sure they don't have distant disease, such that we can properly treat their prostate cancer. For men who have Gleason 6 disease, if they have a very high PSA value, usually greater than 20, or Gleason 7 prostate cancer with a PSA of greater than 10, then we will recommend that they get these fancy x-rays to make sure they don't have distant disease that's outside of the prostate. We categorize prostate cancer into very low risk to very high risk, and then everything else is kind of in between. This is a very fuzzy picture, I apologize for that, of a CT scan. For prostate cancer, we look at the abdomen and the pelvis. So what we're really looking for mainly are there any swollen lymph nodes in the pelvis? Does the liver look healthy? Do the kidneys look swollen, and that kind of thing. This is another very fuzzy picture, I apologize for that, of a bone scanner. So this is a nuclear medicine test that takes a picture of the entire skeleton. I always tell my patients they can use it as a Halloween decoration. It's a very, very creepy looking picture. But it's their entire skeleton, and we can see whether or not they have any dark spots in the bones that might be suspicious for being from prostate cancer. This is just a chart that kind of outlines, I know in a lot of cancers we talk about, stage 1 through 4. You can see that this is not very clear cut for prostate cancer. There are a lot of variables that go into this, so I just have this up here for your reference. How we're going to talk about treatment for prostate cancer is by whether or not it's localized versus advanced.
All right, and we'll stop here for a moment with your next polling question. So which of the following are used in the treatment of prostate cancer? And now you can do A, surgery, B, radiation, C, chemotherapy, or D, all of the above. I'll give you just a moment to take a look at those. If you didn't answer the last question or go ahead and get logged in, you can either go to pollev.com/UNCCN, or on your phone you can text 22333, and once you've done that you put the letters UNCCN to join, and that's a one-time thing. You only need to do that once. We've already got some answers coming in. So over the next few minutes, go ahead and answer this. Again, A, surgery, B, radiation, C, chemotherapy, or D, all of the above. And then we'll come back to this in a few minutes and find out the answer.
Sounds great. Thank you. All right. Ready to proceed?
Absolutely.
All right. So now we're going to get into the treatment of prostate cancer. And the way that I have this kind of broken up is by localized prostate cancer. In other words, there's no evidence or suspicion of distant disease. And then the second half of this is going to be talking about patients who do have distant or metastatic prostate cancer. So active surveillance. Active surveillance is a very appropriate treatment, if you will, for men who have very low risk, or even some intermediate risk prostate cancer. I've listed for you the typical criteria for men who would be appropriate candidates for active surveillance. So relatively low PSA, a Gleason score of 6. That said, we do have some men on active surveillance with higher Gleason scores. Stage T1C to T2A, men who have a greater than 10-year life expectancy and a low volume. In other words, we do their prostate biopsy and find maybe 3 to 4 cores of prostate cancer versus all 12. So how does this work? So since it's not an actual treatment in the traditional, by the traditional definition, it's important that men who decide that this is the best option for them understand that it's important to stick to a follow-up schedule. So it varies depending on patient and provider preferences, but typically folks will come into the office every 3 to 6 months for a blood test, a prostate exam, to see if they're having any urinary symptoms and things like that, and also to make sure they're still psychologically okay with the plan. We typically re-biopsy these folks once a year. I have men who've been on active surveillance for 10 years who've had no change in the stage of their prostate cancer. It looks the same under their microscope. And we biopsy them every 2 to 3 years. So it's not a one-size-fits-all. When would we intervene? In other words, when would we recommend not doing surveillance anymore and doing a more kind of conventional treatment? So if there was a change in the way the cancer looked on the biopsy, so let's say they had a Gleason 6 prostate cancer in 2 cores, if that changed to a Gleason 6 cancer in 12 cores, that's a much higher volume of cancer, and we talk to them about doing a treatment. Or if the Gleason score changed, I've had kind of things happen that we can't really explain, where someone will go from a Gleason score of 6 to a Gleason score of 10, even without much change in their PSA, and we can't really explain that, but obviously we'd want to encourage them to pursue treatment. Even though we have some criteria for this, it's not appropriate for all men who meet the criteria. If a man is going to be very nervous about this or lose sleep about this, this is obviously not appropriate. We want men to be psychologically okay with our recommendations, even if they meet the criteria for active surveillance. Other things to take into consideration are age. Usually our very young patients, we do have patients who are found to have prostate cancer in their 40s. We usually recommend that they have treatment versus surveillance. Men who have comorbidities, so if they are not a surgical candidate or not a radiation candidate, then active surveillance is definitely an appealing option then. And then if we're at all concerned that people are going to kind of fall off the map and not come for their follow-up appointments, then it might be better off in the long run to go ahead and do surgery or radiation or one of the other treatments instead of surveillance. So surgery to treat prostate cancer, localized prostate cancer, is called a radical prostatectomy. So prostatectomy is surgical removal of the entire prostate gland and the seminal vesicles. So there are several surgical techniques that are used. Open, which is one of those traditional surgery techniques you think of where you come out and you kind of got a big scar. Laparoscopic is a surgical technique whereas the surgeon inserts ports along the belly. And then robotic surgery is very interesting. If any of you have the chance to see a robotic surgery done live in the operating room, I would encourage you to do so. It's not the robot from the Jetsons doing it, so that was a little disappointing to me at first when I was learning about this, but it's kind of cool nonetheless. So I've got a picture of a robot that I'll show you. The robot technique is very interesting in that it's typically less blood loss, it's less time in the operating room, and even kind of a faster recovery time. Considerations for this, as with any surgery, are things like age, medical comorbidities, prior abdominal surgery. So if they've had multiple abdominal surgeries and have a lot of adhesions in there, this might not be the optimal treatment. Typically, most men spend just one night in the hospital and they're gone the next day, which is kind of amazing to think about a cancer surgery that can be done and you leave the next day. Men will leave with a catheter, so a urinary catheter that goes through the penis. That's to allow that kind of space in there to heal. And then that comes out about 5 to 7 days after they leave the hospital. They come back to clinic and do that. After prostatectomy, men will come back to clinic every 3 months for the first year, and then every 6 months until year 5, and then annually up until year 10. What we do with these appointments are PSA blood tests. We see how they're recovering as far as symptom and side effect wise and things like that. So this is a picture of a robot. You'll see the surgeon sitting in the green there is driving the robot, and then there's the big robot arm over the patient. So this gives spectacular 4D almost view of the operating space there. It really is kind of fascinating. So radiation therapy for prostate cancer is delivered in a couple different ways. We'll go through that. So external beam radiation therapy is kind of a traditional radiation that you think of, where patients come in and they go through all the physics of getting their bodies measured so that when they lay down on the table, the beam is delivered very precisely to the prostate. Radiation techniques are much more precise than they used to be, such that there's much less damage to surrounding tissue and much more radiation given to the prostate. So the machine is an external machine that delivers this invisible beam of radiation down to the prostate. that's usually done 5 days a week, Monday through Friday, anywhere between 4 to 6 weeks. If men have more of a intermediate or high-risk prostate cancer, they'll also get hormone shots to go along with the radiation. Brachytherapy is another form of radiation. These are little seeds that are implanted surgically into the prostate that deliver kind of a low-dose continuous radiation to the prostate. They're about the size of little tiny rice pellets. This is appropriate treatment for low-risk disease. Prostate size does matter, so this doesn't work well for men who have big prostates. Usually we say not bigger than 40 grams. Cryotherapy and HIFU therapy have less evidence-based and are not kind of the conventional treatments that we think about for treating prostate cancer. Cryotherapy is the surgical freezing of the prostate, and HIFU uses ablative technique using heat. So side effects of all of these treatments that I've mentioned are some degree of sexual dysfunction and erectile dysfunction, urinary tract symptoms, so leaking of urine, bothersome urinary symptoms. Radiation can have side effects like rectal pain and diarrhea, and those are very, very common things that happen after prostate cancer treatment. And we'll go through some management issues that comes along with those things. So, like I said earlier, prostate cancer is very treatable and highly curable, especially if caught early. One of the debates around prostate cancer and whether or not we should even be screening for it is that there is no one best treatment. So there's not been any clinical trials done comparing prostate surgery to prostate radiation that says, you know, one is superior to the other. We just don't have that information. So it can be very stressful for men and their loved ones when they're deciding what treatment to do, because there is not one best treatment, so to speak, when it comes to what the evidence tells us. So prostate cancer can come back. So what happens when it does come back? So now we're going to talk about advanced prostate cancer. So that means prostate cancer that comes back after we've already treated it, or systemic recurrence, in other words, prostate cancer that's kind of gone outside of the prostate, or a clinical recurrence. So a man comes in and they have bone pain, and then we find out they have cancer in their bones. So this is just a list of types of recurrence. The most common is what we call a biochemical recurrence. In other words, a man has radiation or surgery, for example, their PSA should be very, very low. So if their PSA numbers start to come up and start to rise consistently, then we worry that there's an active cancer cell somewhere that was, for whatever reason, laying dormant and now all of a sudden is making PSA again. Then there's local recurrences that can happen within the prostate for men who've had prostate radiation, and then distant and clinical recurrences. So salvage treatments following definitive therapy, so after radiation, sometimes we can offer them prostate surgery. That's technically very difficult and has a higher rate of things like sexual dysfunction, urinary leakage, and things like that. And kind of vice versa, after surgery, we can offer them radiation to where the prostate used to be. So I've kind of touched a little bit on hormone therapy. I mentioned that in a couple slides. So hormone therapy is when we give men shots that basically ablate 90% of the testosterone production that comes from the testicles. We can do this in a variety of forms, and I'll go over that. So for men who have advanced prostate cancer, when do we start this? What are the recommendations? So if there are no distant tumors, in other words, it's just a PSA recurrence, it's okay to delay this, and there's evidence to that. For men who have distant tumors or they're symptomatic from their cancer, we typically recommend starting them on hormone therapy sooner rather than later. So if you think back to the earlier slides, prostate tumors do require testosterone. So what we're doing with this hormone therapy, it's a systemic therapy. In other words, if you think about getting a shot, that goes all throughout the body. It's not just localized to one place. So that's what a systemic therapy is and what these hormone medications and hormone shots are. So hormone shots and hormone therapy and androgen deprivation therapy, or ADT, are used interchangeably. So we can go about this in two different ways. The first way is by surgical castration, which is surgical removal of both of the testicles. As you may imagine, this is not always a very popular choice. This can be incredibly psychologically distressing for men for body image concerns, but it is a good option for men who we might be concerned about things like compliance. The second option, which is much more common, is medical castration. We do that with medications through shots. We also have implants that we can use, and a variety of things like that. The global constellation of side effects with hormone treatment is basically like a male menopause. So things like hot flashes, fatigue, weight gain, moodiness, osteoporosis, sexual dysfunction, cardiovascular dysfunction. So, you know, while this seems like a very simple thing to do, just take and get a shot, it can have some potential consequences that are unpleasant. So it's always really important for us to make sure our patients understand the potential consequences of these shots. So this is a very interesting development that I believe was approved maybe a year and a half ago. So for men who have metastatic castrate-sensitive disease, so what does that mean? So metastatic means outside of the prostate. Castrate-sensitive means they still have a bunch of testosterone. So for men who are originally diagnosed and they're metastatic when they're diagnosed, there's relatively new data that support the use of chemotherapy plus hormone therapy for these men. The clinical trial that was used to kind of push this into mainstream and get it approved showed a significant median overall survival in the men who received chemotherapy and hormones versus hormone shots alone. So almost 14 months longer, which is a really big number in cancer care in these clinical trials. So the name of the chemotherapy is docetaxel, and that's given once every 3 weeks for 6 cycles, and the hormone shots last indefinitely. So what happens after advanced prostate cancer is treated with hormone shots for about 2 years or so? Well, that's typically when the PSA number starts to go up, which indicates that what we're doing with the hormone shots alone is not enough. So then what do we do? So for men who have castrate-resistant disease, what does that mean? That means that the PSA number is going up, but that testosterone remains castrate. In other words, that testosterone remains very low. So what do we do for these men? We always keep them on their hormone therapy, whether or not it's a shot or an implant, because we know that 20 to 25% of the cancer cells are still going to respond to the shot, so we never take them away. They're kind of like the base of the pyramid. You don't want to take away the base of the pyramid or the whole thing will crumble. So we always leave them on their primary hormone therapy. Before we make any kind of change, we want to get updated imaging studies. So that CT scan and bone scan that I talked about a few slides ago, prior to changing any treatment, so we kind of get a new baseline before we start them on something different. So there's a small subset of men who do not have metastatic prostate cancer. In other words, we do these fancy x-rays and we don't find any tumors, but they have castration-resistant disease. So their PSA number is going up, that testosterone is staying very low, we get a bunch of x-rays and don't see any tumors. This is not very common. I have a very high volume of prostate cancer patients in my practice, and I think only 3 of them kind of fall into this category. So what do? We keep them on their hormone shots, and we have 2 additional treatments for them. One is either with an anti-androgen pill, like something called Casodex, that blocks the cell's ability to bind to hormones. And then the second option is a pill called ketoconazole, which if any of you have taken a pharmacology class knows that ketoconazole interacts with just about every medication on the planet. So you have to be very careful when prescribing something like that. But like I said, this is a very, very small subset of men, but it's important to remember that this can happen. The vast majority of men with castrate-resistant disease, again, that PSA going up, testosterone staying low, do have metastatic disease, so big, fat, swollen lymph nodes or tumors in their bones. Like we touched on earlier, this can go to lymph nodes, bones, sometimes liver, sometimes lung, but usually bones and swollen lymph nodes in the pelvis. There are a lot of options. When I started back in 2010, so almost 7 years ago, I had 2 treatments in my pocket. Now I have, I think, almost 7. So the advancements made in treating metastatic prostate cancer has really taken off in the past 5 or so years. There are 2 types of chemotherapy that are approved for metastatic castrate-resistant prostate cancer. One is called docetaxel. The other is a cousin to that called cabazitaxel. They're both given very similarly, in other words, through an IV, once every 3 weeks for a total of 10 cycles. Side effects are kind of like typical chemotherapy side effects that you might think of, so things like hair loss, fatigue, maybe some weight loss, maybe a little nausea. But on the scale of chemotherapies, this is actually on the lower end of the scale, whereas patients usually don't feel very bad when they're taking them, and they're pretty well tolerated. I also have a couple pills up my sleeve that I can offer to patients. So these are relatively new in the grand scheme of things, approved 5 or so years ago at this point. One is called abiraterone, and the other is called enzalutamide. They work a little bit differently, kind of against androgens, which are those hormones and the pathways, whether or not it's the testosterone that's being produced by the adrenal glands or the testosterone that's being produced by the adrenal glands and some activity on the tumor itself. These medications are taken once a day. We typically tell folks to take them in the morning. Typical side effects are fatigue, worsening hot flashes, maybe some swelling, body aches, joint aches, and things like that. I have one immunotherapy. So immunotherapy is kind of a hot topic in the world of cancer care right now. So immunotherapy on a very basic level is something that stimulates an immune response to fight cancer. So Sipuleucel T is the immunotherapy that I have for metastatic castrate-resistant prostate cancer. We don't make anything easy to say around these parts, that's for sure. But the process is such that cells are taken from a patient, prepared by the company, and then infused back to the patient. Side effects are kind of like flu-like symptoms, so chills, fever, fatigue, body aches. And then I have a radiotherapy. So radium-223 is a really interesting therapy. It's mainly for men with advanced disease who have prostate cancer in the bones because we're trying to help with their bone pain. So it's this a radioactive particle that latches on to the parts in the bone that are turning over really quickly, and that's kind of what cancer does to the bones and can help with bone pain. The issue with these 2 treatments is that we usually don't see a response in PSA because they don't have a direct effect on the hormone pathway. So it can be a little bit hard to convince men that they're actually doing something or working. Immune response takes a long time. That can be a really long process. So we usually kind of wait and see how they do as far as clinically, in other words, are their symptoms getting better, and then we'll do periodic scans to make sure that their tumor burden is either the same or getting lower. When do we change these treatments? How do we decide? There's so many now. Is there a perfect way in which to prescribe them? Not really. So we take into account many things such as PSA, testosterone, their clinical pictures, so how sick are they, how symptomatic are they, and what their scans look like. So are there new spots? Are there growing spots? Are there spots that are smaller? So after we do those IV chemo medicines, we just kind of wait and see what the PSA number does. When people are on the pills, we wait until we see a consistent rise in their PSA number and or worsening clinical pictures. So are they having new or worsening pain, things like that. We always get those fancy scans, the CT scan and the bone scan before changing treatment. And that bottom line there is just an example of how one may prescribe these different medications. But like I said, it's not a one-size-fits-all. They're all approved by the FDA for metastatic castrate-resistant prostate cancer. So there's no perfect or right order. It should be very individualized. So I'm not going to go through this. I know I'm giving you a ton of information, and this can seem like it's hard to kind of piece together, but this is just an example of how advanced prostate cancer can be treated, how much it varies, and how different it can be. The good news is that I have a lot more options than I used to, which is wonderful for men and their families.
All right, and let's take a look at that poll and see, obviously, several different treatments, and of the ones listed here, how did they do? You
guys don't need me. You scored perfectly. You're so smart. I'm done. I'm done with no, I'm just kidding. Fantastic. Yep, you guys got it.
All right.
Thank you for answering. Okay. So supportive care is equally as important as treating the disease itself. So when men have advanced prostate cancer, we think about things like their bone health. So they can develop osteoporosis over time when we're treating them with these hormone therapies that make all their testosterone go away. So there are several different options. So zoledronic acid or denosumab are medications. Zoledronic acid is given IV, denosumab is a shot. These are bone protective medications. They don't treat the cancer itself. They're just made to protect the bone from things like fractures. Calcium and vitamin D is important for bone health, as are weight-bearing exercises. If men have bothersome urinary symptoms, so these are men who still have their prostates mainly, so advanced prostate cancer, sometimes we can give palliative radiation to the prostate. We can do a prostate roto-rooter, which guys out there, I'm sorry, I know that sounds terrible, but that's just a surgical procedure to kind of relieve obstruction. And then we can put tubes in things. We don't like to have to do that, but urinary catheters. Bone pain. Bone pain can be excruciating, so we want to maximize medical management with pills or patches or IV medication. We can also give radiation to men who have bone pain. This helps about 80% of the time. Men will notice a difference in their pain. And then if things are severe, if they have a fracture or something devastating like that, then surgical repair. Unfortunately, there is no cure for metastatic prostate cancer. So while it's very encouraging that we have all these different treatments for men with metastatic prostate cancer, I don't have anything that makes it go away. So it's always really important to incorporate best supportive care, whether that's for symptoms, emotional, psychological, and support for the family as well. An important take-home message that I like to kind of push is that it's important to let men know that just because we have multiple treatment options for their cancer doesn't mean that we have to exhaust them. And we should always be talking to men about things like end of life and hospice care if they have a terminal cancer. So side effect management, the two big side effects that I'll touch on are erectile dysfunction. So this goes for treatment of localized prostate cancer and also for advanced prostate cancer. There are a lot of options. So there's vacuum erection device, which is a penis pump, for better or for worse. Pills, which I'm sure that you've seen a lot of those types of commercials for pills that men can use. Urethral suppositories, penile injections, which I know sounds terrible, but they actually have a really high success rate. They have about a 90% success rate. And then the last resort would be something like a penile prosthesis, which is a surgical procedure to put an implant into the penis. So this is just a picture of a type of VED or vacuum erection device. This is the fascinating lineup of pills that are available. The trouble with most of these pills and also with any of these treatments for erectile dysfunction is that they're very expensive. This is a little kind of schema of what it would look like to use one of those urethral suppositories. This is what all of my patients think when I say, hey, let's talk about penis shots. But I quickly assure them that that's not how bad it is. It's a relatively small needle, and like I said, it works very well. And then this is just a picture of what a penile implant looks like. So it's put into the penis, and it's inflated and deflated by using a pump that is placed into the scrotum. This is just a chart that kind of goes through the pros and cons of each of these treatments. For the interest of time, I'll let you kind of look at that on your own. Side effects management, so urinary incontinence can be really difficult for men. Thankfully, after radiation and surgery, the lifetime risk of having, urinary incontinence for lifetime is roughly 5%. So the majority of men will be kind of clean and dry a year after surgery. It's a little bit more delayed for radiation therapy. This happens because there's muscle and nerve damage to the urinary sphincter. I should mention the reason why men have erectile dysfunction after treatment is because the nerves that control erections wrap around the back part of the prostate. So anytime we manipulate those things with surgery or radiation, it can cause damage leading to erectile dysfunction. So things, supportive care things like encouraging them to wear a pad or protective undergarment in their pants so if they were to have an accident, they don't embarrass themselves. Kegel exercises, which are good, healthy pelvic floor exercises. I don't know if I have any physical therapists in the audience, but I'll be the first one to refer someone to a pelvic floor physical therapist in a heartbeat. For severe refractory urinary incontinence, men might choose to have a surgery to put in an artificial urinary sphincter. And that's just kind of a picture of how that works. They can open and close it. Hot flashes. The worst part about hot flashes is that I don't have anything really great for them. And the other bad thing about hot flashes is I don't have a lot of female partners who have a lot of sympathy for their male counterparts when it comes to hot flashes. So teaching empathy is also a really good big part of this. A lot of men, upwards of 80% of men, will have hot flashes when they're on hormone therapy. So we really just kind of preach things like behavioral change, cotton clothes, carry a fan, avoid triggers. So sometimes alcohol and spicy food can trigger them as well. There are some medications, but honestly, none of them work really well for this. But thankfully, most men don't require treatment. So kind of touched on erectile dysfunction. The other component to sexual dysfunction are things like decreased sex drive and penile shrinkage, which, again, we don't have a ton of great treatment options for, but sometimes the vacuum erection device can help stretch out the penis so that it's not such a traumatizing thing for men if they have some penile shrinkage after surgery or while they're on hormone therapy. And this all has to do with the hormone manipulation process. Fatigue, again, I don't have a great, one pill fixes all thing for fatigue. So thinking about things like exercise and good sleep hygiene, accepting help from other people, prioritizing tasks, taking breaks and listening to your body when you need to are all really good things to help with fatigue. And then the emotional part, this part, is stereotypically can be a challenge for some men. So as their healthcare provider, encouraging open discussion, making sure you're validating their feelings. It might not seem like a big deal that they can't get 100% erection, but if they're telling you it is, then it's a big deal, and we should do what we can to help them with that. Involving partners or family members to help with this as well, and also to help family members who are having emotional struggles as well. And then, anytime this gets outside of my area of expertise, I don't hesitate to refer out to my mental health care professionals. Collaboration is key. Our patients, prostate cancer patients, any cancer patients, are never ever straightforward. There is no such thing as a textbook patient. This is certainly not an exhaustive list of folks who touch my patients each and every day. So if your particular profession or something you're studying to be is not on this list, it is certainly not an intentional oversight on my part. But I just wanted to throw up folks out there who have helped me in my profession, who have helped my patients along in their cancer trajectory as well. Each one plays an important role, and one role is not more important than the other. So thank you for what you are studying to be and taking an interest in healthcare. So healthcare provider considerations. It's really complicated. It's so much more than just seeing patients in clinics. So we have to start with counseling patients about whether or not to screen for prostate cancer and managing the uncertainty that comes along with this. Educating about treatment options, side effect management, referring out to our other healthcare professionals when we need to, when something gets outside of our area of expertise, quality of life, best supportive care, and the really hard thing about talking about end-of-life care and referring to hospice for patients who have terminal cancers. There are thankfully a lot of resources out there. All these different organizations have either internet or phone-based resources for men with prostate cancer and their, and their loved ones as well. So if you feel like you don't have the answer to something, I can guarantee you there's someone out there that does and is willing to help you and help your patients. So don't ever be afraid to outsource as needed. I think that's the end of my formal slides.
Right. Mary, thank you so much.
Yeah, sorry for talking so fast.
No, that was terrific, and that was a lot of information to cover.
A lot of information.
You covered it extremely well. Let me go to our Poll Everywhere poll, and let's see if we have any questions. This is a great time. If you have questions for Mary, please go ahead and text those now. Again, you start, if you haven't already done that, with the number 22333, texting the letters UNCCN. You only need to do that once today. Excuse me, and then you can go ahead and text your questions. While we're waiting for some of those questions to come in, I know I had a few. So you mentioned a lot of side effects. And yet, I think I've heard at times that that there aren't as many side effects as there used to be. Is that in fact true? And if so, what are some of the things that are responsible for that decrease in side effects as compared to maybe 20, 30 years ago?
That's a great. The very easy response would be technology.
Okay.
So, for example, for prostate surgery or prostatectomy, like we touched on, big open surgeries always come with more potential consequences.
Gotcha.
So using the more refined techniques like laparoscopic and robotic approaches, the urinary incontinence rates are lower. We can do a nerve sparing technique for men as appropriate to kind of protect those nerve bundles that wrap around the prostate to help preserve erectile dysfunction better. As the radiation techniques have gotten more precise, the side effects are lower. So it really is just a technological revolution that's really helped men and a lot of cancer care.
Good, good. We'll keep looking for those questions to come in. Please don't hesitate to text those in. I know you mentioned going the PSA and the DRE as part of that, as part of the diagnostics. How do you go? What's the process for going from that to the biopsy? At what point do you say, okay, we've got to go ahead and recommend a biopsy, and at what point do you say nothing's necessary?
Yeah. So normal PSA is so variable, so there's a different school of thought on is there a normal PSA for age and race-ish, kind of, younger men, if they have, higher PSAs, then we're kind of more apt to push for that. Sometimes I see, an 80-year-old in my clinic who probably shouldn't have had a PSA to begin with, for better or for worse, and if that's, 4.5, then, we'll probably say don't. This usually, quite honestly, is about a 30-minute discussion for a new patient about what the PSA means, does your prostate feel normal, and the potential consequences of having a biopsy. So biopsy in and of itself is not perfect. If you think about the nature of a biopsy, that's just a snapshot. So, we might take 12 pieces. Just because they all come back negative doesn't mean that you might not have a little bit of cancer. So it's a really, very long conversation, and that's why it's so controversial. There is one tool that I'm using that's out of the University of Texas, I believe. It's a risk calculator, and it's validated, so with research, data-driven, and we type in things like age, race, family history, PSA, prior biopsy, and how the prostate feels. And that spits out 3 different percentages. So percentage of having a negative biopsy, percentage of finding a low-risk prostate cancer, and percentage of finding a high-risk prostate cancer. This has actually been a really helpful tool because it's helped men kind of on the fence say, oh, I have a 10% risk of finding a high-risk prostate cancer. I definitely want to have a biopsy. As long as men are aware of the pros and cons and the risks and benefits, then that's the most important thing. It's all about having a thoughtful conversation. And as you can see, this is why some of the naysayers, they don't even bother with it because it's so, it's certainly not black and white. It's very gray.
Gotcha. Yeah. So if I'm understanding this correctly, one of my big takeaways is that this is not sort of a cookie cutter A to B to C, and that there are a lot of decisions along the way and a lot of gray areas really in terms of making decisions from diagnosis to treatment and different types of treatments.
That's right.
Okay. All right. Well, thank you so much. Let me remind our listeners that we have on March 27th at 1 p.m. community resources for the patient with cancer, and that'll be with staff from the NC Cancer Hospital Patient and Family Resource Center. You can find out more about the PFRC and about what a Patient and Family Resource Center does and the types of resources that are available for patients in North Carolina. So we look forward to seeing you then. We want to thank the North Carolina General Assembly for their generous support of the University Cancer Research Fund and the UNC Lineberger Comprehensive Cancer Center. We want to thank the North Carolina Community College System and specifically Renee Batts and Catherine Davis for their phenomenal support and cooperation with this program. We want to thank Dr. Thomas Shea and Mary King and Alan Brown and Jean Sellers from the UNC Cancer Network for all the hard work they do to make this possible. We look forward to seeing you next month. And also don't forget to check us out at unccn.org. If you found this talk on cancer interesting, we have over 150 different lectures on cancer in our library and lots of other information as well. Thank you so much. Have a great afternoon. We look forward to seeing you in March.